Good afternoon, everybody. It's 1:12. We'll call the governance meeting to order. I apologize for being late. Hopefully, I can run this meeting a little bit more efficiently than Steve can run his. So, yeah.
That was a bang.
Yeah, we will ask Charlie to leave here quickly enough so that we can move on with our meeting. First and foremost, are there any citizens that wish to address the board at this time? There being none, I'll ask for approval of the minutes for the June 22nd meeting.
Second.
We have an approval, a motion and a second. All approve?
Aye.
Any opposed? That motion carries. I don't have much as far as a committee report other than today that we will be without Miss Irma. She is attending the American College of Healthcare Executives panel in Dallas this afternoon regarding compliance. So we're proud of her and the work she's doing to let everybody know about the good work that we're doing when it comes to governance and compliance. I also just want to say to Ron and his team and everybody, Michelle and Irma, that their job is not easy. When I have my one-to-one meetings with them, I can see and how difficult that it is. They're kind of the internal affairs folks, and they do a really, really good job for us, and I'm very appreciative of their efforts. And as a board, we should be as well. If the board will opine, I would like to hold the guts of the meeting off and do our closed session first. I know that we've got a few that have time commitments because of Steve holding his meeting later. We have to adjust ours, but we'll do so. And then we will come back and have the regular meeting and be done and out of here. So if anybody has nothing further, we'll go ahead and go into closed and move that right along. Thank you.
All right. What do we have?
What is it? It's 2:05. We'll re-adjourn to regular session. And thank y'all for allowing us to switch the agenda a bit to accommodate some of our folks. We will move on now with an ERM update and go on with the rest of the agenda. Ron?
Thank you, Mr. Chairman. There are two ERM risk profiles that I want to briefly review with the committee with a little help from my friends. There we go. What I would say is I greatly appreciate the collaboration that my colleagues have had with us and our team in developing these risk profiles, working with their teams for what you're about to see. Before I turn this over to them, one of the items, the first item A on the agenda under ERM, relates to governance, risk, and compliance software implementation. Just a quick word. I've mentioned this too in the prior meetings, but we are about to go live with our GRC software implementation of ServiceNow GRC. And it will give us the ability to automate what you're about to see here today that we have in Word and Excel documents, standardize it in a way, be able to communicate seamlessly, hopefully, with the various other parties, as well as automate the internal audit and compliance processes. So when we do audits, like some of the ones we recently did around patient access, you'll be able to link that work and how it rolls up into this point of view. And I know we've talked about that for a long time, so we're excited about that, and that will go live at the end of September, actually. So with that, I'm going to move on to the patient access risk summary. And we have Wanda, Dr. Duncan, and Diana here to kind of touch on high points. But these was meant to be, and you've seen this format before, meant to be an overview, certainly not all inclusive of all the potential risk around patient access, but some key areas to focus on. So whoever wants to.
Do you want to go? Absolutely. So you've just heard a report about the significance with which we are trying to work on our patient access. We certainly have policies and procedures now, so we would define patient access as defined, and we are going to work to get it to an optimized level, which I think you've seen these before. We identified our top risk, and those were identified by focus groups and those folks who are very close to the process. Certainly, it's not, you have heard that we have an overutilization of our ED by patients who could be more appropriately seen in the ambulatory clinics, and so that is a top risk. Verifying benefits so that we can get payment on the back end, you've all heard that. Patients you have heard about who are not necessarily authorized or pre-certified, so we might have denials if we don't do that process correctly, making sure we get great patient information, and then we've all focused on recruitment and retention of providers, which is you've heard many of the strategies that we're working on for recruitment and retention, including, certainly moving our providers to a pay that's more marketable, that's more competitive with the DFW market. And then we've heard a little bit about underutilization of clinic capacity and how we make sure that when schedules are templated, that providers are filling those, patients are filling those schedules, and providers are available for all the open times of the clinic. We've gone through and put some strategies there, and you can see those strategies as well. Working on communication, you've heard a little bit about MyChart and making sure that we are responding timely, that our patients are using MyChart. We have 80,000 active users, you've heard, and we have some folks using that for bilateral communication, but not everyone, so we'll be working to make sure that we provide a better format for our patients to reach out to their providers and get responses as they need. And those are some of the things that we're doing. If you have other questions about this one, we're happy to respond.
You guys want to add anything to that? Okay.
I think mine was covered in the previous presentation.
Okay. All right. Any questions on patient access? Again, this is a work in process, so we're not done. This is an evolving process, and we'll be coming back to you as we need to belt this out. The next one is care coordination, and who'd like to? Yeah.
Some of the things that we're looking at here are some of our top risks are the availability of outpatient physician appointments, physician staffing, which we discussed in the previous presentation, our lack of capacity in our facilities, holding patients in the ED, the PACU, admit holes, our inadequate case management staffing. Currently, we do not have 24/7 staffing for our case management department. They leave around 7 in the evening, and then so we admit a lot of patients during the night. So we have a big gap there currently, and then on the weekends, we do not have good coverage there as well.
That's changing, correct?
Yes, sir. Yes, that is some of our strategies. We are requesting 24/7 coverage in the ED, and that's going to help us with a lot of things. Prevention of denials, hopefully that those patients will all be screened prior to being admitted, so that we're making sure patients are, we're not taking up beds with patients who really should not even be in the building. By creating a denial of their admission. So that's one of our strategies there. Poor transition of care increases the risk of adverse events due to miscommunication of providers, and then increased readmission rates. By having these case managers, we think that's going to solve a world of these issues that we're currently going through. A couple other things that we're doing is really looking at our patient throughput. We have a patient throughput committee that is constantly looking at new ways of how can we get patients in and how can we get patients out. We meet daily. We have daily bed meetings, sometimes 2 and 3 times a day, depending on the census and how many patients are coming and going. We also are looking at, we have an admit holding unit that we implemented a couple of years ago, and we're looking at that right now to possibly restructure that a little bit. And rather than them just holding admissions, we'd really like to focus on making them not be admissions. So if they just need additional time in the recovery room, in the emergency department, so that we can determine if they really need to be admitted, rather than admitting them to observation or to the ED, making that more of an ED transition unit. So maybe we put the patient there, we wait 6 hours for a troponin, And if it's negative, then we're going to discharge the patient rather than admit them and do a stress test and some of those kind of things. So constantly looking at different ways that we can do things. So I think that's going to be a huge win for us as well. Really looking at our care coordination between our ED and ancillary departments. And just to share with you a little story of how we're doing that is, for one thing we did is our women's services team, OB triage, we were seeing patients who were coming in with, that were having babies and in distress because maybe they've had an abrupted placenta, or they're bleeding heavily, and rather than them stopping in the emergency room and then having a delay or delivering that baby in the ED, which is not an optimal setting, we've worked with the Women's Services has worked with the ED staff and with MedStar to bypass the ED and take those patients directly to Women's Services. And just in the last 2 or 3 weeks, we've had 2 instances since we've implemented this, where if those mothers had stopped in the ED, there was a chance the mother could have been lost or the baby. And because of the severity of having an abrupted placenta. And by doing that, both mother and baby are doing well. So great coordination of care between those departments. And then making sure with those case managers, another thing we're looking at them also doing is making sure we have pre-authorization for these procedures before we do them. Some of the surgery, some of these big procedures that are being requested, like MRIs, making sure we have all those pre-certifications before we do that, which should save us a lot of money as well. So.
Great.
This is all for inpatient. This is just hospital, correct? Does that nothing to do with community clinics?
No, we would be coordinating here with the community clinics as well, so
What it
absolutely.
says is the medical home model is totally broken. If I read the risk definition.
Well, again, the risk statements are meant to be negative statements. So that's the what could go wrong. And so it's not to say that these risk statements are at what actually is happening, but we want to prevent that from happening.
Is there any opportunity to explain this a little bit more?
Oh, absolutely, absolutely.
Because what I don't see is, and I've been saying this for a while,
Mm-hmm.
you need to look at the patient but see specialists without primary care physicians, so you can identify coordination of care problem.
Mhm.
And you can look at the pharmacy stuff also as well.
Mm-hmm.
Because I don't see anything here looking at medication therapy management. Probably you guys doing it, I don't see it.
Mm-hmm.
And stuff like that. I mean, those are some of the areas that, and then what pop up is that we have the one tool in place. But if you guys are waiting for some of the tools, like, helping planet or happy together, whatever they call it, you may want to start looking at different solutions until that thing can go online, because I have yet found a facility that can take advantage of that yet. And if you're waiting for that, you can wait for a while. And all the initiatives might work. If you can find one that are already working, let me know, because I haven't seen one.
Okay. The point's well taken, yeah.
And while you, I guess it's the coordination, this one is the last one, the supply and all that stuff.
DTP?
Yeah.
Right. Order.
And then the last one, when we talk about supply and all that stuff.
Yeah. Talking about
I think-
procurement.
Right, procurement, all that stuff.
Mm-hmm.
Love to see area we can improve spend on pharmacy, the take back,
The span of pharmacy, you say?
right, distribution, and then the take back, people that are not compliant, and they're not showing up to pick up their prescription, all that stuff. 'Cause
Yeah, I remember we had discussed this
Yeah.
well, in terms of the people who don't pick up their prescriptions and the take-backs, those kinds of
Right.
things. Did we? Yeah, I thought we
And then,
looked
you
at
know,
that.
sometimes we order things, and this is everybody's problem, so if we can eliminate the throwaway supplies and pharmacy stuff,
Yeah, save the expense.
yeah, 'cause I'm not sure, I'm pretty sure you guys may have it, we haven't seen it yet, but it's become a problem for the industry. So if
Okay.
we have that problem, we're not the only one, but if we can bring it down find a way of doing it.
Okay.
That's improving because
Okay.
every penny's count.
Yeah, that's a good point. No, I'll take that back. I know in working with our team, we've worked with management about, because this question has come up before, I remember as well, but, so we'll take that back to come back. Okay. So, Mr. Chair, that concludes our ERM summary for these two, unless there's any other questions.
Let's roll into compliance program and reports.
Okay. Thank you, guys. Appreciate it. So I'll be relatively brief on this. There's not a lot in terms of updates, but I know you all like to hear about what's happening in the industry, and so I'm not one to revel in the misfortunes of other people, as long as it doesn't happen here at JPS.
But you will.
With the change of presidential administration, there's been a very large enforcement action activity over the last several months, culminating in the mid-July enforcement action, which is deemed to be one of the largest or the largest healthcare fraud enforcement actions that has taken place in HHS history. They basically, the Attorney General Jeff Sessions and the HHS Chair Tom Price charged and arrested 412 defendants across the country, including doctors, nurses, and other licensed healthcare professionals, for alleged participation in various healthcare fraud schemes amounting to approximately $1.3 billion in false claims, including prescribing and distributing opioids, which is a national epidemic in terms of drug diversion and opioids. And so there was a very big press conference around that in mid-July. Again, this underscores the reason why, just on a diligence basis, and we've talked about this on an ongoing basis, while we do the coding and billing audits and compliance, and and again, it's not that anyone is committing fraud. It's just it changes so much. You have to kind of stay on top of it. And so this is just an example of the enforcement action. The next one is related to a medical record vendor by the name of eClinical Works. It's an EHR vendor similar to Epic, and they were fraudulently certified for meaningful use certification, and so they didn't earn their meaningful use certification. They basically did some technical things to get the certification when they shouldn't have, and so as a result, the government determined that they falsely completed a meaningful use application and got incentive payments, because with meaningful use you get incentive payments, and so that was considered a false claim because it came from the government and was based upon a false application. And so they were charged $155 million to settle this False Claims Act, and the CEO and board members of that organization were held personally liable, and they had personal fines and were also barred from participating in healthcare programs. So again, certainly this isn't Epic, and Epic is legitimately certified in meaningful use and other things, but they're looking at patient status from both observation and inpatient, and okay.
Blame Steve.
I guess they told me to hurry up. And so she's going to review the observation patient status review report at the next meeting. In the privacy and security area, I've talked a lot about OCR mock audit. We finally went through the RFP process, selected a vendor. We're going through contracting right now, and likely this project will start at the beginning of the next fiscal year, in fiscal 18. It is designed, again, to see if there's any gaps that we have in our privacy and security program. During the insurance presentation in finance, you heard me talk about the cyber coverage and other things. This in coordination with IT, looking at both security and the privacy side, will kind of identify any gaps that we might have from a third-party perspective, and I believe will set a baseline for us to work from going forward. This is something that we don't necessarily need to do every year. You kind of do this once, and then you kind of set a baseline, and then you assess after a few years. And then lastly, Maze Analytics, that's a new HIPAA monitoring software. We are in the process now of implementing that as well. I know my folks are really excited about that, and that is, I'd say, it puts us at common practice with most other hospital systems of our size in terms of getting out of the business of doing these manual access reports anytime we get a report that an Epic medical record was accessed inappropriately. My folks will pull out a manual access report, they'll dig through the report, they'll try to figure out which ones are appropriate versus inappropriate, and then they'll talk to the supervisor. And it's not very fun for anybody, I'll just put it that way. And oftentimes, most cases, the access is appropriate in many cases. The Maze Analytics software gives us the ability to have an interface with Epic and Lawson to do this on an automated basis, on a proactive basis. And what's nice about this particular solution, as opposed to thinking that an access is inappropriate, which in most cases it's not, it finds reasons why it's appropriate. So if a clinician added something to a note in the medical record, usually they're not snooping. They're part of the care team. They're adding a note, and so they'll whitelist that access. And so what you boil down to is those that they couldn't whitelist through algorithms to a much more manageable list that we can work through with the supervisor. So we're really excited about that, and that will be in place where we're just in the early stages. So it'll probably be a couple months before we go live with that. Any questions on any of that? Okay.
We're good?
Okay.
Okay.
And lastly, on compliance, this is the time of year, this is the end of the fiscal year, and so we now have finished our process to update our work plan for what the fun and exciting things that we're going to look at next year in fiscal 18. And so to make this less of an eye chart than we've had in the past, what we've done is, Irma and I put this one-page slide to show what the compliance audits that we're planning for fiscal 18 next year that this committee will see next year in the form of a report and a report out. We are still going to do all of the HIPAA monitoring stuff. We're still going to do the program requirements. We're still going to do all the monitors that you see on those work plan updates. And so it's not to say that there's only 7 projects we're going to do for the whole year and that's it. I mean, we'll do all of those other things. To boil it all down, these are the non-recurring projects and audits that we're going to focus on. 2 of these, the first 2 you've seen before, these are the follow-ups for those coding and billing reports around the modifier audits, 25, 59, and XU. We're going to look at emergency department services, look at what are the risk areas around the ED, and from a coding and billing perspective. Advanced beneficiary notices, are we providing those as appropriate, what the process is to provide those to patients, what the billing implications are around ABNs. Anesthesia, same thing. Intensity modulated radiation therapy, which is an oncology radiation service that the OIG, because of the reimbursement associated with it, is kind of on a higher risk than others. It's not to say that we have any issue with it, but since it's on the OIG's work plan for next year, it made our work plan as well to make sure. Also, Kathleen has already engaged a consultant to look at IMRT, that we're going to leverage their report. That's what it means by we'll reassess based upon a report by a third party. So Kathleen's consultant, I think, just finished up their review, and so we're trying not to duplicate efforts when we look at this in 18. And then dental services, same thing as looking, are we in compliance with the various regulatory guidelines and requirements, including Medicaid payments by states for dental services. So I'll stop there, ask if there's any questions, and ask, this is our recommendation for approval of the committee for work plan for next year.
I think it's an ambitious plan, especially with everything continually and ongoing, so have fun. We need a motion to approve
Yeah.
it.
Move approval of their compliance plan for.
I have a motion, do I have a second? Second by DT. All in favor, say aye. Aye. Any opposed?
All right, thank you. That concludes the compliance report.
All right, Michelle.
Okay, we have validated the remedial actions taken on our hospital pharmacy drug diversion control audit. You've seen this a couple of times on a status update. Everything is now green. I specifically want to call out Trudy Sanders, who really helped move this big rock and change the cultural outlook in terms of the at-risk drug handling behaviors that once existed. We now have tighter waste handling procedures, end-of-shift narcotic counts, they're held accountable for those. We have made propofol a controlled substance that we're now putting in our Pyxis machine. And those are just a few examples of the things that have been done to kind of move the culture, training and awareness, things like that. The second item also is green now. We are actually auditing the top 15 controlled substance polls by area and user every week, and we're escalating those. I would caveat that and say that it would be great if we had some automated software to do that. There is some software, I believe, Mr. Adams, you may have Care Fusion contract maybe on RX Auditor. That would help maybe automate that and take some of the subjectivity out of that process if we had that software. The last one is we basically didn't have an overall response and evaluation team to respond in the event of some drug diversion issues. And so what we want to do is, or what they have done actually, is they've solidified the procedures around that, and there are people in place to take swift and decisive action. If there are no questions, what we will do is we'll close out this particular hospital pharmacy audit, not to be confused with the outpatient pharmacy audit, which you will hear from me in October regarding the status update on that.
I'll just ask a question. What was the name of the software? Care Fusion, what?
RX Auditor, sir.
RX Auditor. And was that discussed in around budget time from your department that might be necessary, or?
I believe,
I think it may be complete in the last couple of weeks. It's an amendment to the bigger fusion contract that we
Okay.
have. I think it's probably out of your shop.
Okay.
I think it's too.
so once we operationalize that, I think that was that last dotted I, if we could, in that process, so.
Thank you.
And then, just like Ron has, what I'd like to do briefly is to talk through our fiscal 18 internal audit work plan. We too have a very ambitious goal of completing 7 new projects and 6 follow-up projects. And I'm going to quickly go through each. If you have any questions, please stop me. On charge capture, I like to do a charge capture audit every year in some area, and so this year we're going to tackle the physician side of billing in ICU and cardiology. Outside medical services, we want to make sure we have a process defined to ensure that our medical transfers are appropriate and we're monitoring those to control our costs. Payments to employees, as you can imagine, are quite sizable. And we want to make sure, again, we have good processing controls in place to make sure those payments are appropriate. Point of service collections, what we're really talking about there is a lot of the co-payments. I believe we send about 65,000 statements a month to our patients to pay their co-pays. Yes, sir, you heard correctly. Nutritional services, that's the fun one. I am interested in understanding taste testing, controlling our food costs. Are we, effectively and efficiently operating our room service, our cafeteria, or catering, and controlling those food costs to the best of our ability? You heard David earlier in finance. He talked a little bit about the cybersecurity. And I know that they have annual penetration tests. And so what we're going to do is work collaboratively with IT to kind of gauge the maturity of our cybersecurity program. And then finally, the call center operation. I really want to call this out and give kudos to Ms. Laura Burnside, because a lot of folks don't invite audits, but she did in this case. And right now, she has people staged in the call center at South Campus, and they are establishing a best practice baseline and coming up with better metrics. And she would like us to come through later next year to see how far we progressed and to report back to this board on how well that they've implemented those best practices that they've had a consultant in working on with them now. That is the proposed new projects. The next slide is the 6 follow-ups that we will come back to this board to address. Again, in every follow-up situation, you have already heard from me in terms of briefing the original issues. The only thing that we do on these follow-ups is to revisit only those specific issues to make sure that there's remedial actions taken to reduce the risk to low or acceptable level.
Can I ask a question?
Yes, sir.
You said 65,000 statements a year are sent out for copays?
Month.
A month? Isn't that something
That
that's?
sounds about
typ-
right, right, Sharon?
Isn't that something typically done at time of service?
That's right. That's part of the reason for the audit.
Kind of seems like the audit's done. I mean,
Well, we
It
want to
seems
take a look
strange.
at the statistics behind it.
Sharon has a comment.
No, we attempt to collect copay at time of service, but a lot of our patients do not have their copay at the time of service. So, and
What, do we know the percentage of those collections on those invoices we send out?
I don't have those statistics today. I wasn't aware we were going to be talking about
Okay.
that, so I don't have those.
Okay.
But,
You gonna blame it on the actuaries again, or what?
no, I don't have.
I'd be curious,
If you get above
even if,
11%, you're in good shape.
yeah,
Above 11% would be good.
I'd just be curious to know what those numbers
I'm
are.
not sure what the number of statements that would be directly related to copays would be.
Okay.
So, but yeah, we do ask for the copays. A lot of times the patients just don't have the ability to pay those at time of service.
Okay.
So I'll have to keep you on the edge of your seat until the audit is complete.
Dun, dun,
And
dun.
we'll do the numbers on it and figure
Can we
out.
separate it out, so if it's clinic or lab, or, if that helps, if it's clinic, that's a cheaper one, or
We'll do the best. We'll see how that data is organized and how we can,
But, yeah,
how we
that's a
can
good
put
point.
it all together.
We're gonna have to bring our popcorn to that one, I guess.
If I may, I think this is going to be a good kind of a baseline for us to set with some of the efforts that we talked about that we're going to be doing for fiscal year 18, in trying to kind of reset with the pre-authorizations, especially with some of what Dorothy was saying, like with some of the radiology procedures that are higher deductible items and some of the pre-scheduling that we're going to be trying to implement next year throughout the clinics and those planned procedures. So we can inform patients what their deductibles and co-pays may be.
Okay.
So a lot of that is trying to get out ahead, that 3 to 5 days ahead.
Okay.
So,
A few new people that you plan to put on pre-access.
correct, yes.
Does anybody have any further questions about the audit plan? We're gonna need a motion to approve that plan. I have a motion, do I have a second? A second by Ms. Dorothy. All in favor, say aye. Aye. Any opposed? Very good. I can't wait for that one, that's
Right.
gonna be thrilling.
One thing I'll say, Mr. Chair, real quick, is I really applaud both Irma and Michelle's efforts this year. I think they've come with both have come with very substantive compliance and internal audit reports, and I know personally that their teams have worked very hard on that, and I know we meet with you before these meetings, and so I do want to applaud both Michelle and Irma and their teams on their hard work and good work to the committee.
I'm continually blown away by what I've learned and the efforts that go through with these audits. It's amazing. All
Yeah, we try to do more with less.
right.
Yeah.
Ron, how about district policies? I know
Okay.
we're taking up the room.
Yes, so, yeah, let's finish this up. So there are just a few policies that have gone through the approval and review process for your approval. This first one, LD 300, Conflict of Interest Policy for Employees. This is an update. This policy was already in place, and it just kind of updated the language. I know General Counsel has looked at all of these as well. Just updated the language, the definitions, and some clarification on the policy itself in terms of from its last update.
if I'm looking at all the changes, You just separate down the policies of the.
Yes, absolutely.
Do we need to take these individually?
I think, Neil, is that right?
Do we need to take the policies individually, or can we take them?
No, we need to take them
Okay.
individually, I'm sorry.
Everything is individual. always.
Not always, but most of the time.
Most of the time.
I'll entertain a motion for approval for, conflict of interest employees policy. I have a motion by Dr. Weber, a second by Dorothy. All in favor say aye. Aye. Any opposed?
All right, thank you. The next one is LD 600, conflicts of interest policy for practitioners, for physicians included. And so, again, this was a policy to, again, to help clarify the difference between some of the more specific conflict of interest considerations for practitioners as opposed to JPS employees.
Many of these policies on conflict of interest were all merged into one, and they really didn't fit each other. They need to be separated out because of the different responsibilities. So that's part of what you've got today.
Yeah.
Okay.
Move approval of the conflict of interest for practitioners.
Thank you. And a second by Dr. Weber. All in favor? Any opposed?
Thank you. The next one is LD 1100, Board of Managers Conflict of Interest Policy. And obviously this relates to you all, but the same conflict of interest process I know that has been administered and up to this point. I know that Neil is responsible for administering this. Neil, did you want to mention anything?
Yeah, the one thing I would say is there's two specific statutes, Chapter 171 and 176 of the Government Code that specifically apply to governing bodies, and those have been referenced in the procedure. So this one's up to date with the law. And that's something I file on each board member, and I always have your conflict of interest reports in your file in my office. So we've been doing that now, I guess, for 10 and a half years. So
Is that
that's no difference.
is that a policy that we have to refile that every year?
This one actually is going, we haven't had that in the past, and that's a recommendation that came from some oversight agencies that be the case. And so you will be filing that, and I will be sending that to you annually.
Okay, all right. Have a motion to approve LD 1100?
Move approval.
Motion and a second. All in favor? Any opposed? Motion passes.
Thank you. The next one is LD 5400, Conflict of Interest Policy for Vendors. Again, to Neil's point, this was to be able to break out conflict of interest specifically for the considerations for vendors and third parties. And this is one in particular that I know we in compliance look at quite a bit in terms of ensuring that our vendors stay within the boundaries and not do anything lavish or, tickets or expensive lunches and all those other kind of good things.
Any questions on 5400?
Move approval.
Motion and a second. All in favor? Any opposed?
All right,
Thank
thank you. And the last one, I'm happy to say, is is LD 3300, Americans with Disabilities Act Accommodations Policy, the ADA Accommodations Policy. This obviously was a policy that we already had as well. It was up for update and revision. And so what you have here are the updates to ensure that we're in compliance with ADA accommodations.
Without any questions, I'll seek a motion. Motion and a second. All in favor? Any opposed? All right, very good. All right, Ron, thank you. Well, poor old governance, gets beat up on.
Thank you all.
Big mean finance took all of our time, but I do appreciate you all being here for this meeting with no further business. We will stand adjourned.